There are a few things in cardiac sarcoid based on how it presents. But the important thing, as Ajit has already said, is that early diagnosis is key, because cardiac sarcoid is a disease which has a very high morbidity and mortality, and most of the time just not even suspected to even start treatment. 10 years ago, we were looking at biopsies, and they really failed us because the sensitivity was so less because of the patchy nature of the disease. And over the last decade, we have sort of developed a lot of algorithms in-house, national level, and also the international data has also looked at it very carefully. The three key players that I see today for cardiac sarcoid is firstly the transthoracic echo, and that is the preliminary step in any imaging sequence. And the important things here are the thinning of the basal IVS, the right ventricular involvement very early, and the GLS starts dropping. The next in sequence is cardiac MR, which again portrays exactly what the echo does, but in addition, it gives you the edema, myocardial edema on the T2 weighted sequence, and the mid-wall scarring, which in our series, and Ajit was part of that large series, mostly concentrated in the septum, but it can actually be anyway. And the third player, important player, is the PET-CT. You can do it either with ammonia to look at the perfusion defects, or you can do it with sestimab, and in our case, we used to do it with sestimab, to look for focal perfusion defects which are not consistent with the coronary territory, and multifocal involvement of FDG, both cardiac and extracardiac. Now, the indications again are based on three big bodies. The first is the HRS expert consensus statement, which emphasizes that the screening in all patients, either with an extrasarcoid to start off with, or with an echo which is suggestive of a cardiac sarcoid, must include CMR and cardiac PET in order to make sure that you don't miss it, because the sensitivity is very high. The joint SNMI ASNC expert consensus statement in their guideline again talk about cardiac MRI as an important tool, and PET-CT both for the diagnosis as well as for serial imaging. And the Japanese Ministry of Health and Welfare, which has a large number of patients, the guidelines 2017 and the recent guidelines, in their major criteria have moved up the MR and FDG PET, when initially it was just a mention that these two would be used. And again, in the prerequisite, you have to have a PET-CT not showing involvement of any other organs, namely the skin, eye, and the lung. And an abnormal high tracer accumulation, which is multifocal on PET, again is a very important part of the diagnostic criteria for cardiac sarcoid. So when we look at the body of evidence, we come with this algorithm that anybody with an extracardiac sarcoid has to be investigated with a transthoracic, and if he doesn't have the features that I just talked about, you can continue the clinical follow-up. But if he has it, or if there's another clinical suspect of cardiac sarcoid, which we know either has an arrhythmia, brady or tachy, or unexplained heart failure, the CMR is the first in the sequence, simply because it is non-invasive, it is easily available, it's cheaper, and the gadolinium is easy to get, is available on the shelf, unlike FDG, which has to be made. Once the CMR is suggestive, we go down the track in almost all patients and do an FDG, because FDG gives us the extra cardiac visualization, and also the edema is then quantified by in terms of the FDG uptake. We call it the SUV max, and that serves for us as a baseline, because many of these patients who have an abnormal amount of LG and they come with, for example, a VT storm, after the initiation of treatment as per the guidelines, then in many cases we do an ablation or we do an ICD, and therefore MRI becomes very difficult to perform later on, and it's the PET-CT that we look at down the line, either every year or every 6 months, depending on the institution. Now, when we talk about PET-CT, we must understand there are three important things that we need to look at. for getting a good quality scan, because one of the big dangers of FDG is that if it is not done well, then you get a lot of artifact, and most of these studies are simply uninterpretable if they're not done in the right way. And the way we do it is a 48-hour low carbohydrate, high fat, high protein diet, followed by about 8 to 12 hours of fasting. And then we give unfractionated heparin about 50 units per kg, half an hour before FDG. And what we get is a very, very good quality scan. And that becomes a very important resource to start with. So as you can see here from the meta-analysis, the PET is very, very sensitive, but the specificity is a little bit of an issue. And if you look at the meta-analysis 7 studies, you can see that the area under the curve, when you use PET as the initial diagnosis, you have a 90% sensitivity to pick up this very, very deadly disease. But what is also important is the prognostic value of the PET. If you don't have an abnormal FDG and you don't have perfusion defects, your survival curves are excellent. While if you have both a perfusion defect and an FDG, which is multifocal, then you have a 4 times increase of MACE. And that's very, very chilling. And we have had those kind of patients who have actually come to us with for devices. And then when we looked at them, they had sarcoid. And when we didn't put in the therapy early, they have just not made it. What is also important is the baseline FDG. If the SUV max is high, both in the extracardiac and in the cardiac, that serves as a very, very important predictor for treatment response. So higher my SUV max to start with, greater is going to be my improvement after I start immunosuppressive therapy. So that's another thing that we look at. And more the number of segments showing FDG uptake, again, that is also going to be a better prognostic marker for the future after starting immunosuppressive therapy. And you can clearly see here that the LV starts to improve, especially if you started with a higher FDG to start with and then started immunosuppressive treatment. And these are 2 cases where we see a high FDG multifocal uptake with a high uptake index. And this is a complete responder, and he responds with an improvement to NYHA class and also an improvement in the ejection fraction. And at the end of 1 year has no residual defect compared to another patient, similar presentation. He has more scar on the gadolinium enhancement on MRI, but very little FDG uptake, and they don't respond to the immunosuppression. The EF starts dropping, the NYHA class goes down, and the mortality is high. So the second important thing is the serial PET scanning. So it's good for diagnosis, but it is even better when you do a serial scanning because as the SUV drops with immunosuppression, you can clearly see here that you can actually start tapering off after 1 year or 6 months, and you can really taper down the immunosuppression. But if there is no resolution and the FDG continues to be high, it means you need to change your strategy. You need to add on more drugs. In fact, we have used other immunomodulators like the TNF alpha blockers when the conventional immunosuppression doesn't work. Otherwise, you're going to get into trouble if the FDG doesn't start dropping. Now, what is the problem with FDG? Fasting, the heparin, and the low carbohydrate diet is a very difficult thing, let me tell you, in our last decade of experience in Indian vegetarian patients. They sometimes simply do not, accept. And so therefore, you have a very patchy uptake. It becomes very hard to really make a diagnosis. So therefore, we have new tracers in the market now. The gallium dotonac group of tracers, which are somatostatin-based tracers, are very, very specific. And also, they are more sensitive to pick up the extracardiac sarcoid, which becomes very, very handy just in case the patient comes a little more advanced to you. He has more scar, very less FDG, but the mediastinum is showing good lymph node uptake. And this is also an advantage because you can actually take a biopsy from there, because cardiac biopsies, again, have their own issue. We all know that. So choline analogs are now coming into the market. Thymidine analogs are coming, but Dotanoc is the one that we have started now getting in India, and some of us have started using. Now, what about cardiac MRI? As I said, it is the second in the sequence after transthoracic echo, and we would always do an MRI before we go for a PET scan, simply because of this triad of the edema, the focal uptake of gadolinium, which are basically granulomas, and also the easy availability of cardiac MRI and the volumetry ejection fraction that it gives us, because most of the data is based on the improvement of ejection fraction and the volumes after successful treatment. Cardiac MRI also has a very good ability as a multi-parametric tool, because it can look at edema. The T1 mapping again is very sensitive for diffuse fibrosis, which we know is reversible, the wall motion abnormalities, and the focal uptake and the ECV. These are all excellent tools we can use on a single study of MRI. And again, all of them can be incorporated in the same sequence without any problem, and they are well standardized. So when you're looking at features on MR, whether it is an unlikely case of cardiac sarcoid, right up to a patient who has a very, very clear cut diagnosis, MRI gives you the entire range of images. And patients who have multifocal LG in a very focal pattern with a regional motion abnormality more involving the basal IVS is very, very classic for sarcoid. The other important thing is the role of the involvement of the RV in R series, especially at the hinge points, are again very, very typical for cardiac sarcoid, because as you know, there are a lot of diseases that again compete for cardiac sarcoid in the diagnostic end. So if you have a patient who is highly probable, the alternate diagnosis is actually very little. These are MRI data. Whereas if you have an unlikely patient, most of the patients would have an alternate diagnosis. So the triad of finding on MRI, the wall motion, the scar, the lymph nodes on the MRI, and the T2 weighted edema are very, very crucial in making the diagnosis of cardiac sarcoid. And newer techniques in MRI are now helping us quantitate the RV and the LV, and making sure that when we give treatment, the follow-up is also really good. What is also important, if patients come little later and they have more gadolinium rather than the inflammation, their prognosis is not so good despite all efforts. And while we have a good concordance with the PET in many cases, there will be cases where the MRI is completely different to what the PET scanning shows. Partly, as I said, is the PET preparation becomes an issue, so we need to be very careful. There is good Indian experience. This is the group from Dr. Lokhandwala. Again, showing very early imaging has helped to decrease the mortality of this disease. And this is our own group, and Dr. Tachal was the lead author of that paper, where we used a combination of MR, PET, and HRCT, looked at the nodes, looked at the myocardium, sampled those nodes very aggressively because they were in the extramediastinal area, and we did cultures, we did PCR, and there was still a group where we could not figure out whether it is sarcoid or tuberculosis, and we actually gave both, and we had very, very good outcomes in those patients who had a lot of FDG to start with perfusion defects, rather than those patients who had more delayed enhancement on MR and less FDG, and they did actually very well. So in the final approach, you need to suspect this disease clinically by ECG. They come as bradytachyarrhythmias, they come as explained heart failure. We want to go through the route of CMR. We want to make those triad diagnosis and then switch to FDG PET, a good fasting regimen, or use the new somatostatin analogs. And those patients who have more of FDG and less of gadolinium are the ones who are going to do well with immunosuppressive therapy. Thank you very much for your patient hearing.